Thanks. Let's go ahead and get started. I want to introduce our speakers. We have two really great speakers today. First is Dr. Reuven Pasternak. He is a physician by trade, both in critical care and anesthesiologist. He spent his training at Johns Hopkins as well as practice medicine, then went into executive roles, and most recently has served for the Department of Homeland Security as well as CISA as an advisor. And so we're really looking forward to his perspective today. And then with him is Josh Corman, who is the founder of I Am the Cavalry. He's a former senior advisor at CISA, and he's also a fellow member of the Healthcare Cybersecurity Task Force. And just thrilled to have him and his expertise as well as Reuven. So how this is going to work today is we're going to give them 30 minutes to divide and conquer some slides on the topics that were in your materials. And then we'll open it up for 30 minutes of committee discussion, Q&A. And so from here, Reuven, I'll let you take it over.
Okay, thank you. So I'm going to share screen. Thank you for having us on, and it's a special pleasure also to be sharing a podium with Josh. So if you have that on, Josh and I came on at roughly the same time as part of the COVID task force, and Josh will be covering that in more detail. So he and I have been partners up through this past weekend, and it's truly been one of the pleasures of my career to have the chance to work with him. What we're going to do over the course of the next half hour or so is I am going to give an introduction in terms of the cybersecurity infrastructure security agency, just to let you know who we are, and to lead up into the stresses that healthcare was facing even prior to the pandemic. And at that point, Josh will take over and go into some of the creative work that he led at the task force, which has given us a new understanding of the importance of cybersecurity. So as many of you probably know, CISA is the youngest federal agency, the fastest growing federal agency, and the one that is committed to assessing risk for the entire federal platform and to defend today and secure tomorrow. As it says here, we're the nation's risk advisor, not just for cybersecurity, but for the full range of infrastructure for healthcare and the other critical functions of this country. So within that is the National Risk Management Center, which is where I sit. And our role is to analyze strategic risks, lead public-private partnerships, and to collaborate. And this is very important, collaborate with the private sector and other stakeholders to better understand future threats and to develop strategies to mitigate those threats. There are two branches within the NRMC, the Planning and Coordination Division and the Analysis Division, which looks at the analytic functions and is the Risk Assessment Division within the NRMC. And so that very rapidly takes you from the broad level of Homeland Security down through CISA, down through NRMC. When we look at the critical infrastructure of this country, there are 16 critical infrastructures that are identified as crucial for the operation of this country. They are not equally large, and I would say for many of us, they're not of equal immediate importance. Healthcare and public health is one of those 16. Although as you look at these, they all share common issues with regard to exposure to risk. And there's a critical amount of interdependence between the two. Obviously, healthcare can't work if we don't have water and electricity and other functions happening. Those other functions can't work if the healthcare infrastructure breaks down and they lose the healthcare of their workers and other support personnel as well. So these are all interdependent phenomenon that CISA has been charged with developing risk assessments for, working in coordination with the SRMAs, the agencies that are principally responsible in those areas, which in our case is Health and Human Services. To support this, the 16 functions, there are 55 national critical functions, which are subdivisions of those 16 sectors. Each of these in turn are responsible for discrete activities that are critical for the national function. And there are 3 that are healthcare related. Undermanaged, and they are in the area of medical care, which is the traditional aspect of healthcare as we think of it, hospitals, clinics, home health services, management of direct contact for individuals. And there's the population-based care, the public health aspect of the care, which is a broader enterprise, which includes those areas that touch non-traditional healthcare, but certainly have a direct impact on the health of our populations, and medical records and maintaining access to medical records. Quite a long list of items here in the area of connect, distribute, manage, and supply. And when we look at the framework for the national critical function, it's divided into further subfunctions, systems, assets, and components. And this is a work in progress that we have going now, which is very much a in-depth analysis of the separate national critical functions, how they relate to each other, and the risks that are posed when one breaks down at whatever level to other entities within its own function, as well as other functions in the nation or in the region. So when we assess national critical functions in action during COVID-19, one of the major contributions of the task force that Josh led was to identify multiple national critical functions at concurrent times and to look at the impact that was had. And when we viewed these functions were actually named. So you had workforce, you had transportation, the various different phenomenon, supply chains, for example, and the extent to which risk drivers, events that were being encountered at the time, were driving problems in these national critical functions. And these were assessments that were being done as close to real time as possible. So to the theme of what we're talking about today, dependent on real-time data as much as it could be achieved. And also here we see the first introduction of the driver scale, where it is a low chance of national scale disruption, green, through yellow and red, progressive levels of threat to the operation of a national critical function, and hence through the performance of the overall health and economic well-being of the nation. So we have a unique challenge in looking at the health sector. And looking at where we are located now, it is conservatively 18% of the gross domestic product. So right away, if we're talking about impact on health sector, we are talking about a massive undertaking, trying to gather data and make sense of an analysis of trends within this area. When something happens in healthcare, its impact also is usually immediate, so that what happens as a disruption in a single day will have its effect in that day. It will be pervasive and it will be profound. By pervasive, I mean covering an entire region or beyond, depending on how wide the disruption is, and profound in that when you disrupt healthcare, it has an immediate effect on people in the region. The health is immediately affected, security is immediately affected. So there's little time to try and sit back and assess and gather data in a complicated fashion. You need to know where you are and how extensive the risk that you're facing is that moment. In addition to this, as I know many people here are familiar, it is a highly fragmented enterprise. There is not an American healthcare system. There is an America with hundreds of healthcare systems. And these healthcare systems are located by states, regions, by regions which are multi-state, in some cases multinational, covering multiple jurisdictions that often gather the information on the same item in very different fashions. There's also a high degree of restructure and a high degree of complexity, so it is very much a moving target, in that at the same time that we are trying to get our arms around what is happening in healthcare today in data sources, new types of delivery and delivery systems are opening up that do things in their own fashion, generate their own data sets, and add further to the integration challenges on a digital platform and data platform of assessing where we stand. The last time I'll put is in their data reporting overload, and that is, are we moving to a situation now where there is so much data that is being requested by so many different sources that we are losing the perspective of establishing a data set that is as immediate as possible, comprehensive as possible, and provides an action-oriented and policy-oriented ability to make the best decisions, sometimes within a very limited framework. That is something that we have been very conscious of as well, and something that we hear a great deal of from colleagues. So I'm giving you now the closest to a whiteboard drawing because that's essentially what this was yesterday. And we're leading up to the issue of resiliency in healthcare. And resiliency in healthcare is a term that we have all heard extensively. We've probably heard very different definitions of it. So in this example, if you look at the blue wavy line would, for example, be census, number of patients in a hospital, number of patients in a hospital ICU. It varies over time. There can be considerable seasonal variations. So what philosophy do you use in terms of addressing the ability to cope with it? Well, you can staff it so that you never have any doubt about the ability of having the resources you need, no matter how much you see in terms of a surge, and perhaps staffing at 105%. Or you can staff at 95% and say that the circumstances when you exceed your limits are rare, and you'll kind of reach into having everybody do a little bit more, pay overtime, bring a few additional people in and somehow tough it through. And then you can have the phenomenon, as we see here, where, as we have in the case of the pandemic, a rapid decrement in the resources and rapid increase and sustained increase in the demand on what we are doing. So up until the pandemic, it was very common to have our resources somewhat strained. We started off with assumptions of 80% occupancy of facilities. It was running closer to 90. We had thought that we might be at 100%. It was closer to 90% in many areas of the possible staffing. So we already had in a steady state situation, an issue of stress on where we were. If you look at that yellow line at the 95% staffing, what we were seeing even before the pandemic was a decrement in staffing, especially in bedside clinical personnel, especially among nurses, so that the resources available were going down. What we also saw in the course of the pandemic was that the variability of admissions and the variability of bed filling was going up to and beyond the 100% level and was sustained, so that what you had is what we term a resiliency gap, a persistent gap in the availability of resources to be able to care for a group of patients who had immediate need for care, and the resulting frustrations and concerns that go with that. You can also include in here the problems with supply chain and supplies that were in short supply, medications in short supply, and even inappropriate and inadequate number of beds in wide swaths of regions to deal with these patients. This was the reality of what we had, first in rotating regions for the pandemic, then increasingly nationwide as well. So in a model that was developed for the task force, and you'll see Josh presenting this in a different context as well, and I want to give credit to Josh and Jeffrey French and the team, the analytics team of the task force, who developed this graphic. What we have is a situation where we go left to right, describing what we see in a region as facilities start to get stressed. And as the resiliency of one institution starts to fade, especially if it's a major institution, other institutions close to it and surrounding it start to have impact as well. So in the model on the left, each institution has some ability to absorb resources, absorb patients, and take care of issues. As you progress on, there is increasing stress, as you can see by the color-coded system, up into a point where you may have across a region an entire cascade that results in the inability to care, to meet the needs of the region, and no place within that immediate area to go to provide the additional increment of care. And we're talking about urgent care, not even elective care. And in a regional degradation, which is something that might have been thought to be hypothetical, but actually has occurred during the course of the pandemic, where the resources of healthcare are so overwhelmed because of supply chain issues, staffing issues, facility issues, that the only way to provide care for patients is to either go into a crisis standard of care and lower the resources that you normally make available, and or send them to distant locations where perhaps that might be available, but increasingly was less so as the situation became more problematic throughout the United States. So as we go now into what we have faced coming on to the cybersecurity issues about which we'll be hearing, is a series of surges, and each surge placed us in an increasingly stressed situation. So as we had an increase in demand and commodity shortages and workforce shortages, each time we came out from a surge, we came out less strong than we went in. It wasn't returning to a steady state situation. We had fewer staff, we had fewer stresses on our supply chains, more stresses on what we had, and an increase in the baseline load of patients. As you do this successively, as you see in the diagram that's on the right of this slide, you go from usual patient care to stress contingency of care to crisis standards of care, where your ability to maintain what is viewed as a basic standard of care in terms of staffing ratios, in terms of appropriate placement of patients, and in terms of provision of a full spectrum of care becomes very compromised. So you get to situations such as being unable to provide elective care, and some of the elective care being not quite elective care, and being able to sustain a standard of care that's necessary for the community. We have had across this country crisis standards of care declared for regions and in some circumstances statewide because of the inability to, across an entire state and sometimes beyond, bring forth those resources that are needed to provide for the care for patients who are in immediate need of that care. So as we start getting into need for data and what we measure, one of the things that we had identified that we were missing was the ability to identify entities or regions and put them into a categorization that at least gave some initial indication of where they stood in terms of their ability to meet needs for their populations. This is a disruptive event level system that actually Josh and I had developed based on our separate experiences, mine in the medical field and Josh in the cybersecurity arena. Interestingly, apart for decades, and we came together in an afternoon and realized we were totally on the same wavelength in terms of doing this, where we had levels 1 through 5. I won't go into all of the dots on here, obviously, but they represent a progression from a situation in level 1 where you have normal operations, you have a situation of resiliency, you can absorb more volume or be able to sustain a slight decrease in your staff or other resources and still meet the needs of the community. It goes on to level 2, meeting standards of service, but limited ability to absorb more. And then 3 and 4, progressive decrease in resiliency, progressive decrease in the ability to absorb patients until you get to the point where, especially in 4, where now you have to close some services. You cannot operate at your basic level of operation. You need to divert patients to other locations. You need to divert people who are going to have elective surgery, and it may be elective surgery for cancer, cardiac, neurologic, other serious conditions. Community services cannot be sustained. Those resources have to be used. And then in level 5, where a facility is so overwhelmed, it cannot function at all. And all of those individuals have to be transferred to other locations. And this covers the full range of disruptive events that, such as resource issues, cyber issues, in the color coding on the right, sudden increase in acute demand, an environmental event, or infrastructure. What we have had in the course of the pandemic is not only the issue of infection, not only the issue of increased demand from infectious disease, but in cities like Houston, overwhelmed with COVID patients, sustaining a hurricane, sustaining a power outage, and sustaining a cyber attack. So this has been a time when we've had a convergence of disruptive events in our healthcare arena, such that we now have, in this, back to this conceptual model, not only hospitals that are coming out because of these events and regions, but coming out because of a convergence of a host of issues that threaten the ability to make and sustain healthcare. Again, not as theory, but as actual fact, and Josh will go into more of that information for you. So that we have, as a consequence of this from the pandemic, a rapidly evolving situation where we have had sources of disruption to healthcare having a direct effect on the healthcare system, and at the same time seeking to establish a methodology to be able to put these into an assignable matrix with discrete levels of interference and also metrics that can be rapidly measured to provide directional input into where these systems are going. And I know Josh is going to get into some of this as well, but I want to give this as an introduction to the level of the quick cascade of challenges that we have faced in healthcare over the last year and a half. And then I'll ask now that we turn it over to Josh, who can take this further along, give you some of the more dramatic impact on healthcare. And here is my email address. I'm available if anybody wants to contact me afterwards for more information or to discuss. So with that, Josh, if you'd like to come on the share screen, and I guess we'll take questions after that.
Okay, thanks, Reuven. I think you have to stop sharing before I'm allowed to try.
Okay, here we go.
All right. My name's Joshua Corman, and up until a week and a day ago, I was the chief strategist for the CISA Code Task Force. I have had the privilege to work with Jackie on the 405C Congressional Task Force on Healthcare Industry Cybersecurity. Please let me know. The bad news is my public service has ended for 18 months. The good news is I can speak more freely and with more candor that Jackie is accustomed to. Can people see?
Yes.
Okay, I'm not going to use builds. I'm just going to, for brevity. So I'm one of the reasons I was chosen to run the CISA COVID task force or design and implement it with a massively multidisciplinary group of people is that as an altruist, I founded a group called IamTheCavalry.org, a volunteer group of hackers trying to save lives through security research. Our tagline is wherever bits and bytes meet flesh and blood. We're deeply concerned about the increasing dependence on digital infrastructure in areas that can affect public safety, human life, and national security. And it's through deep collaboration with the U.S. Food and Drug Administration, Department of Transportation, U.S. and foreign governments to try to bring order from chaos and make sure the dependence we place on this digital infrastructure is dependable and trustworthy. And that has not been the case. In fact, things have gotten pretty bad. And we've done things with models like our Hippocratic Oath for connected medical devices. Let's speak in the language of the people we're trying to influence. And this became a blueprint and a roadmap. And it merely says that this smart digital infrastructure should handle failure. How do you avoid failure, take help avoiding failure without suing the helpers, capture, study, learn from failure, contain and isolate or fail safely, and respond against future failure. And some of these elements may show up in the letter this group is working on as minimum viable capabilities to handle hyperconnectivity in medicine. Now, when we first started, this is a river in Ohio called the Cuyahoga River. It caught on fire and stayed on fire. The pollution got so bad that the public consciousness had to tip. And I was warned that no one would listen to the cavalry until people died first. And while we've had deaths and we knew that we could have deaths, a law professor, Andrew Matwishin, said, Josh, no one's going to listen until the river catches on fire and stays on fire plural times. Apparently, this river caught on fire 22 times across a 70-year period before they built the Rock and Roll Hall of Fame here. But the EPA was founded eventually when people said enough is enough. And we have had fires. We've had a lot of fires. And to build on and come back to the pandemic, to quote Reuven, we had seams and cracks in healthcare before the pandemic. The pandemic made it worse. So a few weeks before Jackie and I had our very first congressional meeting for the task force, Hollywood Presbyterian Hospital in Los Angeles got hit by accident by the SamSam ransomware. And I was deeply concerned that we're going to have a loss of life. They had to divert ambulances to next nearest facility, which in LA traffic is not something you want to do when you're bleeding. You need time-sensitive care. But it was not intentional. But after this accidental hit of this piece of ransom, hospitals became the #1 target. Later on, we thought, well, if we just fix medical devices that allowed this thing to be hit, maybe that's enough. But we saw $100 cameras, internet-based cameras, created the Mirai botnet and took out the internet for a day on a Friday right before the US presidential election. And this led Congress to say, we have this tsunami of technical debt from insecure and indefensible technologies, which eventually led to other things. Our task force built upon this overdependence on undefensible things. And without going through the whole task force, to echo Reuven's point that we had seams and cracks, the headline graphic from our very long report from a consensus was that healthcare cybersecurity is in critical condition. And I was deeply concerned. This is not just a HIPAA thing. I love my privacy. I'd like to be alive to enjoy it. And we had more incentive and motivation and regulation to have a corpse with their privacy intact than to keep patient care available, resilient, and keep patients alive. Some of the seams and cracks we elevated out of 100 or so was that about 85% of the 5,600 hospitals in the US don't have a single security person on staff. They're not fortunate enough to have someone senior and risk-based like Jackie. Number two is they're defending really old equipment that's not supported anymore or not patchable. It's overconnected to each other and the outside world as a perverse accident of meaningful use requirements that incentivized premature connectivity. These vulnerabilities aren't just about your privacy. They affected patient care availability. The unavailability of patient care can be not just a single floor or a wing, but an entire facility or even your affiliate networks. And a typical device had over 1,000 known exploitable vulnerabilities. And even if only a handful are exploitable, it only takes one to shut down patient care. So that was what we were coming into. And we had hospitals screaming, but we can't afford this. Don't make a standard we can't meet. To which initially and flippantly, we said, if you can't afford to protect it, then you can't afford to connect it. The more Stan Lee Marvel Universe-ish version that was a little softer and kinder was that with great connectivity comes great responsibility. And we have this digital divide where we don't want more accountability because we don't have money, but we also want all the benefits. And with that great power comes great responsibility. And we really have to find ways to identify and buy down risk to close the gap between where we are, where we need to be. So as we were reeling from that, WannaCry affected 40% of UK healthcare delivery as the largest attack to date. As we were trying to talk to the international policy community about the implications of that attack, NotPetya accidentally escaped its blast radius. And while most of the headlines were about the $1.4 billion of damage did to Merck, it also had severe damage to hospitals and healthcare delivery in the US. Most notably, Nuance Software, a voice-to-text dictation service, was so entangled and entwined with patient care suitability for surgeries. There were 2 children depicted in this book that couldn't get timely surgery because they couldn't extract the records from Nuance's cloud that was down from a ransom attack. So when we think about patient care, and it's not just about patient privacy, we know from a seminal New England Journal of Medicine article that even a 4.4 minute longer ambulance ride during a marathon can affect mortality rates 30 days later for heart attacks. 4.4 minutes was enough to measure the difference between life and death for heart attacks. So what does that have to do with cybersecurity? Well, what it tells us is degraded and delayed care affects outcomes. So we did what any self-respecting hackers would do. And we said, if no one's going to listen until someone dies, let's kill people. And we started killing people through the CyberMed Summit in ER hacking simulations. So we took normal simulations that doctors do all the time for rare conditions. We took actual hacking, combined it with actual physiology. And at least in the initial one, we hacked an insulin pump to empty its full contents, causing the driver of a car crash, pass out. Number 2, the very first medical recall in history affected by our group and the FDA was a bedside infusion pump. We gave a 3-hour dose of a calcium blocker in 30 seconds, causing a heart attack. And the third one, the most perilous one covered by ABC Nightline, was a subdural pacemaker defibrillator giving an electroshock every minute on the minute. And eventually the surgery was required to remove that. The doctors had no idea it was coming. We want to give them an experiential thing about this is the art of the possible. And as we increasingly depend upon connected technology, we may have bits and bytes meet flesh and blood. So we started running 1 to 2 to 3 hour tabletop crisis simulations in Arizona, now in San Diego. And we've now branched out to OR hacking simulations of changing the blood type for the patient to see how that could be noticed or prevented, or if it would complicate things. And we even proved you don't need to touch a patient at all to lead to a loss of life. The golden hours or hours for strokes, we have life-saving treatments that can bust a clot if you have a clot causing your stroke. But if it's a rupture, you'll bleed out. So the very life-saving thing depends upon availability of imaging in a timely manner. And when patients couldn't get imaging done and the next proximal alternative care was too far away, we started to see adverse outcomes in simulations. All of this was prior to the pandemic. And during the pandemic, we also saw telemedicine increasingly dependent upon, and outages of the cloud backend rendered multi-million-dollar radiation delivery machines incapable of performing their functional service, even though the device itself was probably fine. So as Reuven and I shifted into the pandemic and we saw those seams and cracks shattered, by additional strains and constraints in supply chain and staff and storage and space. You might recall the sober milestone when the US hit in February, 500,000 dead Americans to COVID. What my team started looking at is excess deaths on top of the COVID deaths. And at the same time period, we had about 150,000 excess deaths. Excess deaths are determined by the CDC as the difference between expected deaths and actual deaths by cause, by state, by time of year, and are tracked mercilessly. And among those, I was unsurprised to see that degraded and delayed care for things like our favorite heart attack example from the New England Journal of Medicine. If some of the top contributors were heart, brain, pulmonary, diabetes. These were not older folks with comorbidities. The number one age demographic was age 25 to 44 as the fastest growing age demographic. These are young, critical infrastructure age workers. So if 4.4 minutes can affect mortality for heart attack and 4 hours is the difference between life and death for stroke, what do you think 4 weeks did to the state of Vermont for their protracted and pronounced disruption from cyber attack in November and December of last year, a year ago? So we studied that, and I'll show a couple of graphics in a second, but in parallel, before the pandemic, we now also have our first front page Wall Street Journal story on the first alleged victim of a cyber attack, a baby in Alabama pre-pandemic. The hospital had degraded and delayed functionality of their equipment, admitted anyhow without adjusting for diminished technology assist. And ultimately, they're likely to settle out of court just because there was too many admissions and interceptions between staff saying we should not have admitted this patient or the outcome might have been different. But as you look at this patient care, we forget there are sometimes dozens of computers and connected technologies that help us support that care. But at the center of everything should be the patient care itself. Now, some of that study that we did, we now have the first, in addition to the first acute probable confirmed victim of a loss of life due to cyber attack, we now have statistical proof of loss of life. My team looked at public CDC data. We eventually published this in the Morbidity and Mortality Weekly Report. And we also cross-referenced with other public data sources from HHS, including adult ICU bed count and utilization. This is a proxy indicator. It's a trailing indicator. It's an imperfect indicator, but during the pandemic, it's an incredibly strong indicator with peer-reviewed p-values. And what we found was during pre-pandemic conditions, 75% bed utilization was optimal. But during the pandemic, it's quite fatal. And the further north you get of 75%, the faster the impact accrues, with excess deaths 2, 4, and 6 weeks later. And moving quickly at this pace again, armed with this instrument, we could see that if the country got to 75% bed utilization, of which many northern states at the beginning of flu season were well over 100%, if you got to 75%, you'd see 12,000 excess deaths in 2 weeks for a total of about 30,000 across 6 weeks. If you hit 100%, you'd see 80,000 excess deaths in 2 weeks with additional tranches 4 and 6. So we published this on October 1st. I encourage you to read it. This is where bits and bytes meet flesh and blood. Notice the title is that provide medical care, which is our nomenclature for that national critical function, is in critical condition, much like our task force report from 2017. And what we really wanted to do was enable that state departments of health, hospital administrators, and others could control the strain on ICU. Net ICU utilization is the key here. And what was initially published last time last year, was a model for a city-wide failover. Began to manifest as a statewide failover for Idaho or for Texas or for others who had to send plural states away. Again, these top contributors were heart, brain, pulmonary, diabetes. What might have been a surgical diabetes consult may lead to a deferred, degraded visit and a sub-knee amputation, taking this critical infrastructure out of the workplace and occupying beds we don't have. Again, the fastest growing demographic was age 25 to 44 back in February, March. We reran that data, but then we said, can this instrument to measure hospital strain tell us anything about cybersecurity? Can cybersecurity make it worse? And we looked at states hit hardest by ransoms for a 5-month statistically significant observation period in the same state with the same population during the same pandemic, from a 5-month slice view, looking at hospital type and hospital size. Hospitals hit by ransomware achieved these fatal excess death ICU strains sooner and stayed there longer, allowing us to have the first statistical proof that bits and bytes can kill. we can strain hospitals sufficient to lead to loss of life and adverse outcomes. So these protracted delays take a long time to recover from. It's not just the HIPAA violations. It's not just the cost of the incident response. It's not just the fines. It's not just the ransoms you might pay. It's not just the $67 million of lost revenue on a public earnings statement from one of the victims. But now it's also degraded, delayed patient care outcomes and even loss of life. Now, when we put these together in a conceptual model, that initial cyber compromise in number one initially leads to a diversion of ambulances to next proximal alternative care. This is an evergreen part of the model that even post-pandemic will tell us how bad it can be if a regional or rural hospital is offline and doesn't have nearby treatment for heart attacks and strokes. Ultimately, that leads to increased surging in column 3 for ICU census. And then ultimately the excess deaths in the time of the pandemic measured 2, 4, and 6 weeks later. So as we look at this, we need to get, we don't want to go back to normal. It was stressed and strained before the pandemic. The stresses, the pandemic further revealed the system dynamic. And part of my hope and solace here is we have lines in the executive order from a year ago. One of my favorite took one of our recommendations from Jackie and I from the need for a software bill of materials or a ingredients list of all the third-party open source software used in medical technologies. The White House has now pushed this to all federal procurement. And the lines here that could be our North Star are things like, in the end, the trust we place in our digital infrastructure should be proportional to how trustworthy and transparent that infrastructure is, and to the consequences we will incur if that trust is misplaced. And what that means is we can't merely say this is all we can do and all we can afford and use unsupported software that's not patchable or has hard-coded passwords or is directly exposed to the internet, or we're doing the best we can, but really push through that. And if you don't think the pressure from the White House is material, when it starts to be covered by comedians on HBO, and it's a whole segment on how ransomware is affecting hospital care and how most hospitals are ill-equipped to deal with it, we're going to lose the institutional trust of the public to know that we're going to be good custodians, both of their data, emergency or otherwise, and their lives for timely available patient care. So we really encourage that we get to some first principles. And I really like the letters moving from maybe consider these things to, these are things we really need to do right now. They can't be optional. These are table stakes for delivering hyper-connected medicine, because best practices from 15 years ago aren't anymore. Good enough security isn't, and it's being measured in mortal consequences at this point. It's going to take courage, because if you believe we're doing the best we can, you'll sadly be a self-fulfilling prophecy. But I would like to remind us that Semmelweis was trying to warn us for 100 years that we should probably scrub in and be more hygienic when leaving the morgue before delivering a baby or doing a surgery. And it took way too long, and ultimately dramatically improved mortality rates for post-op. And this stubborn jerk took something like childhood leukemia, which was a near death sentence, and now it's one of the most survivable conditions, in the pursuit and dogged belief that we weren't doing our best and there could be more to be done better, invented platelet things and bone marrow samplings and the cocktails now used emblematically as modern cancer treatment, at least when the ransoms don't lock up the medical records for a month, preventing us from knowing those cocktail recipes. But people have to say good enough isn't anymore and fight through it. And as Reuven reminds me, the quality movement also dramatically improved things. So this group is on the cusp of, we're going to ask the right questions and balance the right equities to get the right information, to share the right information so we can manage and buy down risk for timely available healthcare for such a lifeline bottom of Maslow's hierarchy of needs. So with that, the solution isn't going to come from somebody else. My belief and philosophy is the cavalry isn't coming. What are you willing and able to do within the sound of your voice? And what can we push for to be better? So I said a lot, but thank you for your time. Remember, this is not just about records. This is about the availability and timely delivery of patient care for you and those you care for.
Thank you, Josh and Reuven. I have lots of questions for you, but I want to open it up to the committee members to see what questions you all have for Josh and Reuven.
I was privately messaged to go to 3:20, so I hope I properly heard that.
You properly heard that from the chair.
Well, we're certainly happy to take any questions by email that folks don't have time to give to us here and to share. The time is tight.
So Josh, while we wait for the committee members to have questions, if you were in our shoes, what would be the top two things that you would push for, knowing that we currently have a draft security letter in our hands?
So I didn't include it in my remarks, but I do recognize that divide for the haves and the have-nots. And unfortunately, like take CISA has free taxpayer funded services to do cyber hygiene scanning of anyone in critical infrastructure. Out of the 5,600 hospitals in the country, for all of the healthcare and public health sector, we have less than 200 signed up for this free service. Something could be scanning you for free and telling you when you have a known vulnerability. And even if you can't fix everything, you can at least fix the very small list of known exploited vulnerabilities we also maintain. And that might be the difference between highly available healthcare delivery for the rest of the pandemic or being down for a month or more. So I think while there's different aspects of the HIPAA rules and the new discretion from the secretary on HIPAA fines and other things, we have started with an ongoing assumption that we're doing the best we can and we can't do more. Current status quo is quite dangerous, and increasingly so as adversaries are more brazenly attacking. So I would say we should identify what the minimum table stakes are for connectivity. And if people can't meet that bar, we should assist them in meeting that. So admiring the gap is over. It can't happen any longer. And one of the things that CIS has done is we have a CISA.gov/bad practices, which is the most egregious and dangerous practices for industrial control systems in hospitals. We have a get your stuff off search, which is for free, how you might see what adversaries can see to at least remove the low-hanging fruit and shut the front door. So this kind of pragmatism shouldn't point at best practices that may be well out of reach for people that are below that poverty line, but can get people up above negligence on things like bad practices or wanton exposures or using unsupported end-of-life software in service of national critical functions. So it's going to be uncomfortable truths, but if we go back to normal, it wasn't very good to begin with, and it's much more imperiled now.
Reuven, do you have thoughts on that question?
I want to add one more thing to something that Josh had already mentioned it when he said we likened this to the quality movement before. And one of the things when we had that imperative, because lives were at stake there as well, is we didn't negotiate quality standards. We established what they were based on evidence, based on what was needed, and said this is what needs to be done to protect patients. And that was a starting point. What's needed to protect patients and do it right. And then going from there, establish the models that could guarantee that that type of care and service was delivered. And so as we embark upon this, I know we will hear we can't do that, as Josh had said, but we have to. And it will be upon us to develop the clinical and business models that will allow us to get that done. And Josh has already explained what some of those are.
Thank you. Rich?
Yeah, thanks. I was intrigued by your remarks in passing about the Office of the National Coordinator and the unintended consequences of moving too far too fast with the connectivity. So the question is, has CISA had conversations with ONC to talk about mitigation and more importantly, being a little bit more circumspect for future?
No, I would say the answer is no, not to my knowledge. Prior to the hiring of myself and Reuven in the CARES Act, people like to stick to their lanes, and very few people have fully embraced the intersectional risk management capabilities of CISA. And I think we're pretty far from that trust being sufficient to do that. If you'd like to catalyze such a meeting, I'd be happy to participate for any of the hats I've worn before. But there's still the sibling rivalry of sorts that sub-optimize the outcome for the American people. And to put 30 more seconds on that statement, meaningful use tying reimbursement to the ability to receive and transmit electronic health records took devices that were never designed or threat modeled to be connected to anything and incentivized the rapid connectivity to everything. So it's not like it was done to cause harm. It was an inadvertent byproduct of that hyper incentivization.
Clearly understood, and there was intense political pressure to get the connectivity done.
Yeah.
So thanks.
Mm-hmm.
I'm teaching a 15.9-year-old to drive, and there's an awesome responsibility that comes with driving a car. Less so for riding a bike, more for a car. But if I wanted to drive a tractor trailer, I'm not even qualified. So I want proportional diligence and proportional risk management for the levels of proportional connectivity and ability to harm.
Denise?
Oh, this was fascinating and eye-opening. I knew the problem, but probably not the scope. I loved how you presented it. So what I'm saying is consumers and patients aren't aware. Like my mother used to say when we were doing quality measurement requirements, she said, why are you doing this as a part of the state government? I thought hospitals did it. I just assumed everyone was measuring quality. Same with computer security. Will this leak into our certification and quality measurement systems to inform the public if the hospital is responding or not? Because next time if I go for a procedure, I want to ask this question of the hospital. Are they fully secure? And I don't even know what to ask, but.
Right. There are several leaders in and around I Am the Cavalry Cyber Med Summit, folks like Jackie, Reuven, who are trying to get this into the zeitgeist, but the future is here already. It's just not evenly distributed. And I think we've been very reluctant out of fear of legal exposure to admit that cyber insecurity can lead to loss of life. It's time to rip that Band-Aid off because this singular opportunity can be wasted. And what people should stop wondering is, did I do something wrong or might I get caught? And rather, let's acknowledge that you're the victim of crimes, often international crimes that have the ability to affect public safety, human life. And if we have to right size our level of cyber resilience and connectivity to be proportional to the risk landscape, when I started the Cavalry, it was in the wake of my mother dying from a hard to treat cancer. And so I understand the promise and the peril of medical advances. It's both. We often adopt things for their immediate and obvious peril. I don't want to slow hyperconnectivity and valuable medical breakthroughs in telemedicine. We need those. What we want to do is make sure they're proportional. We have to understand the cost and the benefit, the risks and the rewards. And even though there's been bold leadership from Suzanne Schwartz at FDA to do safety communications and recalls for cybersecurity issues before we saw loss of life, doctors are still reluctant to believe it. We had a recall of 750,000 pacemakers with a 3-digit hard-coded password in them. And most physicians said, it's too risky, don't do it. But they don't yet know how to size or characterize the risk until we show them through cyber simulations like the CyberMed Summit. So we have not internalized the true cost, and our best selves will be when we can confidently innovate, knowing which risks are worth it and risks are not. Risks are not. And there's much more material on another day, but I feel like I've abused your window of opportunity here and will gladly answer more questions.
Thank you.
Deb?
Yeah, so thank you very much for your presentation. It was very informative and scary at the same time. So what it begs to me, so we have, of course, our HIPAA standards that payers and EHRs and folks have to abide by and so forth. And we have government comes in and they'll do an evaluation and say whether you're compliant or not. And sometimes people are whistleblowers or whatever, and we have ways to sort of enforcement, right? So to me, and Jackie, this maybe puts a little fire under that letter, is I think that every healthcare organization should have a report card that is online so that we can see what is the relative security of your data and these systems that are going to be plugged into your potential heart or whatever, that we could see before we decide to go to this hospital versus that hospital for medical attention.
Deb, this is Reuven. Thank you for that. I would add one other thing that we need. One of the concerns that Josh and I had when we first started on this journey was that getting the information about what's happening at the time it was happening was problematic. So if you're hearing that ambulances are being diverted, we're not doing emergency surgery, and then somebody says we're not having disruption to the clinical enterprise, that tells you right away that there's a gap between what is being presented and what is existing in fact. So it's even getting into the heart of that matter there and requiring that that data be available in a way so that that real-time assessment can be made.
Absolutely.
And policy reform will be data driven. So when we started saying, could we at least have a 1 to 5 scale of patient care availability, your ability to deliver patient care? Because what we want to know is year over year, how many times do we have a level 2 outage or worse, and for how long? So am I affected? To which extent? For how long? And at the federal level, we don't have the authorities or infrastructure to ask for that telemetry or to do that yet. And it's kind of federated across state level and the Joint Commission and different things.
But right, shouldn't we though? Like this
if
is
we're going to manage
important.
health, right? If we're going to manage health with data, we're going to need to know what are the common areas of weakness and how do we do this? In fact, Jackie and I didn't just point out problems. One of the best ideas we had in the task force report was a cash for clunkers program. One-time buyback of certain really old, really dangerous devices that could be modernized, because we don't just want to point out problems. We want to make sure that there's federal assistance to assist with the most egregious exposures, but that's a shared responsibility.
Right.
Yeah.
Thank you.
We have about 8 minutes left if there's other questions.
I didn't put it in the slides, but CISA.gov/bad practices currently has 3. There'll be a 4th one shortly. There's probably going to be less than 10 when we're done, but these are things that are dangerous. They're common and dangerous. And the first one after the Microsoft Exchange attacks was that a researcher found that the #1 market share on the internet for Exchange was the unsupported version. So we just put a stake in the ground and said the use of unsupported software in service of critical infrastructure and national critical functions is dangerous and materially elevates risk to public safety, economic, and national security. It's especially egregious when remotely advisable with the internet. We talked to a majority of hospitals are still running unsupported Exchange and have no plans to fix it. So it doesn't matter what best practices we're doing if you're running an indefensible unsupported thing at the gateway into the hospital, or an electronic medical record system with a hard-coded password, or very large medical equipment from very large medical device makers who won't let you change the password if you wanted to, because it might void the maintenance contract. So these common and dangerous practices are probably the first place to start.
Denise Love.
I don't want to be too cynical, but as you talk, I think about all the fax machines still in operation across the whole healthcare system, and some of the resistance to moving away from fax. And maybe the fax is more secure at this point, and we shouldn't be pushing people off fax. I don't know. I don't want to be too cynical, but that was a random thought as you were talking.
The fax machines turned out to be an analog lifesaver for some of these protracted outages that weren't anticipated. And even the Navy teaches sailors celestial navigation with sextants now, so that we are not over dependent on undependable things, or their electronic warfare in the theater of war. So there are belt and suspenders. There are analog fallbacks you don't want to have to need. But I'll tell you one more tiny anecdote. In the first CyberMed summits we've done, and every one since, every time we do a tabletop crisis simulation, one of the first things the leadership of the hospital says is, let's use the paper records. Let's fail over to paper. And every time someone says, sir, we can't do that, or ma'am, we can't do that. And they said, well, why not? We print them out. I tell Congress we do that. And they said, we stopped training our students on that 8 years ago. They've never seen one before. So like, we have a lot of assumptions about how prepared and resilient we are, and a lot of them need modernization. And the pandemic really revealed that to us.
Tammy.
If we have time, Josh and Reuven, can you expand a little bit more? You gave a lot of reasons why the small, mid-size, let's say physician practice. I know we're talking about hospital systems, but really it's any patient setting that exchanges data. Yeah. Why they do not have at least, one person dedicated to privacy and security. And I know with funding, and you talked about some, but can we glean from your knowledge? Is it the message? Is it understanding the urgency? Is it the total inability to dedicate resources?
Tammy, I'll take a stab at that, since and Josh will follow, since that was my world before I came in here. adding physician groups, adding hospitals. I will tell you, one of the principal drivers we had of people seeking us out in various relationships was their inability to sustain a sufficient IT platform across the entire spectrum, whether for security or the other aspects of communication. So I think part of it is some just don't recognize. I mean, we're still there. Some don't appreciate it. The other is some think that you can buy it on the cheap, or that they're not going to be at risk because they're too small. I think what we're ending up with very, very rapidly is a fundamental change in the business model of medicine because of this and other similar factors, where small entities simply do not have access on their own to the level of sophistication that's needed to be able to meet this threat, because you may have the small entity, but they're facing the same sophisticated threat that the 1,000-bed institution is facing as well. And they're more vulnerable because they don't have those defenses. So I think it's going to be a change in the business culture as well as the culture of operations.
Yeah, you have to first admit you have a problem. And I think no one thought this would ever affect them until it did. And I think when they do see it, they see it as overwhelming, or they think insurance will cover them, but insurance lost a lot of money. They're not in the business to lose money. That's changing fast.
Yeah.
And then when they do go to evaluate it, the supply chain they're getting isn't very robust or trustworthy. So this is a multifaceted issue. But it starts with things like increased transparency, increased accountability, avoiding the known dangerous, known bad practices, and holding our suppliers to a higher standard. I mean, some of the worst offenders are some of the biggest brands in medical technologies, whether they're medical devices, electronic medical record systems providers, biomed services platforms. We take an already weak enterprise and we make it weaker by the standards we walk past are the ones we endorse. So I think it starts with recognition that we have a problem, and then we can make very smart and methodical improvements to make more trustworthy, resilient healthcare delivery.
Last question, Janice Chrysler.
You're on mute.
With regard to meaningful use and the lessons learned from meaningful use and systems being connected that should never have been connected, I'm just wondering about all the money that's now going out the door for public health data modernization and interoperability, and how long public health has waited for those funds. Is there likewise a similar risk in connectivity?
Incentives incentivize, sometimes reversely, right? So there's always the law of unintended consequences. And I don't think the intent of meaningful use was a bad one. It just was incomplete. Like, had we tied it to that you must have a threat, we call it a threat model, or that you had to meet certain minimum standards as well. Or, I know that the Joint Commission switched more to a points system of aggregate points, but I think the use of incentives isn't the thing we don't want to throw the baby out with the bathwater. We may need to use financial incentives. The question is, do you measure twice, cut once, and have you factored in all of the equities and trade-offs? Many of which were balanced yesterday, different ones, but the value of sharing the data under emergencies versus the privacy preserving aspects of it over time. And these are hard discussions, but to maintain the public trust and do something that's 18% of our economy and a vital part of public safety, human life, those hard equities need to be balanced properly, and maybe with hackers at the table, helpful hackers.
Internally as well, you face some hard decisions, and it means that sometimes instead of getting that extra robot, you need to be getting something that truly has benefit for the entire organization, and make that difficult choice as well. It's a priority.
And can I add one more thing in public health, Denise? It's not so much the loss of money that I fear, but one bad, high-profile breach from an interconnected, breach, losing patient data. The way people feel about government and public data right now will just blow up, a lot of trust, and that's what keeps me up at night.
Institutional trust is very hard to win back.
All right, Josh, Reuven, thank you so much for this conversation and joining us this afternoon. We just really appreciate your perspective. And now, team, we're going to tackle the security ladder.